Hello and welcome to the latest episode of Medical Ethics Unpacked, where we explore topical ethical issues in healthcare. I'm Dr. Steve Levine, and I'm joined as always by my co-host, Dr. Dominic Sisti. Today's focus is on organ transplantation, and we're very lucky to be joined by a distinguished guest expert, Dr. Arthur Caplan. Without further ado, I'll hand over to Dom to introduce our guest and today's topic. Dom?
Thanks, Steve. It's great to see you, Art. Dr. Caplan is a world-renowned bioethicist and the division chief of medical ethics at NYU. Art's been busy for many years, writing hundreds of papers and dozens of books in bioethics on topics ranging from sociobiology way back in the 70s all the way out to organ transplantation ethics, which will be the focus of today's podcast episode. So it's really a delight to see you again, Art. I have all kinds of questions for you, things that we've talked about previously but want to rehash, but other things that are brand new, because a lot of action these days in the space of organ transplant ethics and allocation of scarce organs.
Yep.
As we've talked about over the summer, that big news piece came out in the New York Times, and I thought we'd start there. Just to get us like moving on the conversation around why this is just such an important area to know about and think about as clinicians. So in that article, there are several cases reported. This is in the New York Times in July. Several sort of disturbing cases linked to what we call DCD, donation after circulatory or cardiac death, where patients' hearts started beating again, or at least there was a pulse that was detected in several cases where investigation found that some of these organ procurement organizations, or we'll call them, I guess, OPOs, pressured hospitals and families into donating their loved ones' organs. This obviously blurs the boundary between proper end-of-life care and organ procurement. That's why we have very, strong, hopefully strong firewalls between the organ harvesting team and the palliative care or critical care teams. But just, your first impressions are from that one article. Is this something that's been happening a lot? Is there, an increase in these kinds of controversial organ harvesting practices? And what's driving all of this?
Well, there's certainly a problem. And I think it has gotten worse in the past year, maybe 18 months. The problem is pressure on the system to deliver more organs for transplant. Transplant has been increasingly successful. You get outcomes with hearts and kidneys where people expect to live 10 years. Again, not really a cure transplant. You're kind of substituting a chronic illness for a acute one because you have to stay on all these immunosuppressive drugs that make you sick and can damage organs. But nonetheless, something that people surely are desirous of when they're in kidney failure and heart failure and liver failure and so on. Many more centers doing transplants than there used to be. So it's lucrative. It's a very well reimbursed and profitable area. It's prestigious. If you have a academic health center and you don't have a transplant center, people start to look around and say, "What's wrong here?" So we have more transplant centers, honestly, than we need. They should probably be consolidated so that fewer places do more transplants. But nonetheless, they are. Just to give you a comparison, I think we have about 120 liver programs in the US. I think Canada has 4. I
Oh,
mean,
wow.
it's like way beyond need. Prestige, money, and also convenience, to be honest.
Right.
Patients said, well, I don't want to travel from, Bucks County all the way to NYU to have to get a transplant. Set up something in the Lehigh Valley, set up something in Philly, and make it easier for me to get there and my family to visit me and to recover in familiar surroundings. So these have all played a role in generating demand. Regulatory oversight has been saying you're wasting organs to these OPOs. This is the organizations, or 50 of them, that divide up the country into regions where they're responsible for getting cadaver organs, not living ones. That's a whole separate
Right.
living kidney donor. But if you're going to donate upon death, one of these agencies will have the responsibility to come to the hospital and discuss that option with the family and try to ascertain whether the person who died had filled out and registered to be an organ donor. So they've been under the heat from the feds saying, you're wasting organs, we need more organs, get more organs. And more, they're showing up and putting a lot of pressure on hospital staff taking care of patients to get organs. Even when a family says, I'm not sure we want to do this, you get the organ procurement person from the region saying, well, he registered as an organ donor, so we're going to override you and do it anyway. Is that legal? Yes. If you fill out your organ donation bequest, it's binding. Is it ethical? I don't think so, because you don't want to get in a situation with the family that's bereaved is protesting. I always feared that headline: "Widow screams in hall while surgeons remove organs from husband," kind of thing. It's not a good, not a good look.
It sounds like you're saying that off the bat, that the firewalls that Don mentioned at the top may not be sufficient to mitigate perverse incentives in the system.
Yes, and I think given profitability, given more demand, given even to say, Steve, the high cost of dialysis and the number of people using that, and it's growing, whereas kidney transplant is somewhat of a will save you money if you get people shifted over there, so the feds are interested. Our barriers have always been the OPO doesn't talk to the family until the treating doctors decide that death has occurred. So you're not supposed to cross that communication line. Another, we don't remove any organs until you are declared dead. We call that the dead donor rule. Other protections, you're not supposed to really evaluate the OPOs on the number of organs they get. You're supposed to really evaluate them. This goes back to something I argued for, I don't know, 45 years ago, on whether people thought the choice was treated well and they were given the opportunity to say yes or no in an informed way. In other words, what's supposed to happen is you get to decide. It's not, oh, well, if you didn't get a 10% increase in organs as an OPO, then you're no good. You could be doing fine if people turned you down as much as if they said yes. All of those protections are being corroded by these pressures on the system. One other thing is happening. As those transplant centers spread out, more and more hospitals are involved in referring donors, and fewer of them, I think, have adequate training to manage even the pronouncement of brain death. So remember, the only people who can be organ donors when they die of solid vital organs are people who are on life support. You can't just fall over in the corridor and become an organ donor. So you have to be in the hospital on machines, and you have to be free of infectious disease. Your organs have to be in relatively good shape, except for whatever it is that's killing you. So the odds of being an organ donor, even if you sign up, they could be as rare as 1 in 100. It's very unusual to be able to be an organ donor. It's not common. That said, smaller hospitals may not be so adept and may lack the adequate training to say, here's how to pronounce death when it has to be brain death because you're on machines which are keeping the heart functioning. You need to be able to measure, electrical activity in the brain, do the clinical diagnoses that's necessary. I think you really you need to have a fairly competent neurologist around to do this. And in some of the cases that Dom's talking about, they're not there. So these are all problems with the system.
Yeah, let's back up, Art, because you mentioned the dead donor rule and and now we're talking about brain death, and maybe just provide us just a brief history there of brain death, the brain death criteria, the impact it's had, or the reason it was really kind of invented, and maybe discuss like where the controversies are today and if that's creating confusion and controversy around when or if to harvest organs from a particular patient?
Well, I was actually not present for the original organ donation, which involved a living donor and a brother in at the Peter Ben Brigham Hospital in Boston, all the way back to 1954. Organ donation began as something that could only be done between living persons because we didn't have those little freezers to run organs around, the things you see them lugging out. We didn't have the jets set up to fly people here and there. And people weren't even sure whether you could take an organ from a dead body and make it work. There were some animal studies that indicated yes. You needed to have the people in the same place. So you had to literally be next to one another in the surgical suites to do living donations. Those are kidneys. And you also had to have biological matches. So that's why it was a twin brother, I didn't even say. So very restricted at the origins. What happened was we had breakthroughs in a number of areas. We saw the emergence of these life-supporting technologies, think respirators, ventilators, heart and lung machines, they all appeared. Even the creation of the ICU sort of took off. And by, I'm going to say, late 60s, people were thinking, hey, maybe we could do operations from dead bodies. But what we have to do is find some way to get past the biological differences between the would-be donors and the would-be recipients, because they're not going to be twins or even family members, they're going to be strangers. We had progress there in immunosuppression. Won't bore anybody with all the details, but tools began to emerge, drugs that would tune down the recipient's immune system and let them accept an organ from someone who is biologically different. So that led to the explosion in interest in cadaver donation. The one other obstacle was if you were going to do cadaver donation and you had all these machines, then how would you know when someone was dead if the machine was still functioning to replace natural heart function? And there were two answers to that. In Europe, some people said, look, what we do is we take people off the heart-lung machine, we see if their heart does anything further, and we pronounce them dead when their heart doesn't do anything for a couple minutes. In the US, people began to say, well, I think we could agree that you're also dead if your brain stops working totally. Ethicists, lawyers got into that discussion. It was one of the first times bioethics worked with medicine to really come up with a policy, and the idea was brain death. And again, brain death means the total irreversible function of the brain, meaning not that there can't be some cells firing, but you don't have any integrated function, so your heart isn't going to work because the brain can't direct it. You have no thoughts, no feelings. You're essentially absent from life. So that was approved by law in many states. And then eventually the hospital accreditation and neurology communities all approved it. Great. So now we have a system, all the pieces are in place. The question then becomes, what are we going to do as public policy to get people to make organs available? Should we pay them? Should we just take them, presume consent? Or do we ask you to volunteer? An altruistic approach. And altruism won out. So what's really interesting for those who don't follow this closely, transplant is built on a very special moral foundation. You have to altruistically want to donate your organs, or your family can do it if you don't tell them that you don't want to do it. Unusual in the US when everything is for sale, everything is compensated, but here you've got this altruistic approach to why we get organs. And there was a reason. People got nervous that if you paid, people would suspect that you were going to try and kill them early or not treat them aggressively because you wanted their parts and you wanted the money. So it's long been a fear, right up to the present day, that people would act too quickly to take your vital organs out if you had the wrong incentives. The old incentive was, we're not going to pay you, you have to be altruistic. We made these other rules, the dead donor rule and so on. And today, with many things becoming commercialized and transplant becoming highly profitable, even though you still have to altruistically give, people are starting to worry that the push is on because the hospitals want to make money,
Mm.
not the individual family member or survivor. That was the old fear.
On the brain death or definitions of death point, in the cases in this recent story, we were talking. They're talking about donation after cardiac death, which is distinct, right, from brain death. So,
Yeah.
how are organs harvested in the DCD type protocols, and then if you want to talk about normothermic perfusion and how that works as well, that'd be good.
So as technology improves, there's always an interest in seeing whether there are other roads to get more organ donors out of people who have died. Brain death means you've got to have this rare occurrence, as I say, where somebody's on machines in pretty good shape. They've just suffered maybe a traumatic head injury. And that really reduces the pool of potential donors significantly. Most people die from heart failure. So there's been a movement for some years now, Europe and the US, to say, look, maybe what we can do is still salvage organs by allowing people to be pronounced dead using cardiac death as the signal of death, and just say his heart stopped, his breathing stopped. And then maybe things like the kidneys could be salvaged. People don't really believe you can get a heart that way because the heart needs oxygen steadily. And if you're waiting minutes, you're going to have a damaged heart. Although there's even some pressure maybe to try some of those. But the general idea is expand the pool of donors by starting to use people who suffer cardiac death. Obviously, this has to be observed. Again, it's not someone who has a heart attack in the street. It's people who have heart failure in the hospital, so that you can get in there relatively quickly and procure organs. Um, that means speed becomes important because you don't have as much time to have that conversation with the family.
Mm.
So there's pressure on that OPO to say, look, we got to do something here. If you want to be a donor, he registered. What do you think? You want to go ahead? You don't have the luxury of saying, before we disconnect machinery, we've got brain death. You can have an hour, 2 hours, 3 hours to think about what you want to do. So that heats up the situation. There's one other irony, and that is, and both of you will undoubtedly be a little surprised at this. People wonder whether we have the right criteria for brain death. Do we know what we're doing? I don't worry about that. I think we have very good definitions: totally reversible loss of brain function, criteria, no response when you try to breathe on your own. You take people off the machine. It's an apnea test, they call it, and you don't get breathing. You get no reflexes. You get no pain reflexes. We know what brain death is and how to, if you're well trained, you know what to do. Cardiac death has never been defined. So if I wander around the NYU hospital and go floor to floor, and somebody said to me, how long do you wait after the heart stops before you declare somebody dead? If it's me, an ancient person of maybe less popularity to my colleagues for yelling at them all day long about ethics issues, maybe about 30 seconds. If it's a teenager who is just, getting into the prime of life, you might try to resuscitate them 6 times, 7 times. If it's a 90-year-old with many comorbidities and they've already had a resuscitation, you're going to call cardiac death relatively quickly.
Right.
But cardiac death is not well defined, and that leads to problems for
Hmm.
organ donation because you see some places say, well, we'll wait 2 minutes. And somebody else will say, well, we'll wait 4 minutes to see whether the heart does anything. And then all of a sudden, once in a while, a heart pumps a little bit, which is true in some of the cases that we've heard about this year. Does it mean that the heart function is coming back? Who knows? We never studied it. There's no clinical trial to say whether you're gonna. I don't think many people who've been pronounced cardiac death, dead by cardiac criteria, who get a little more heart pumping, are going to be jumping off the table the next day and going home. I mean, that's not. They're usually really sick, but it still makes people very nervous. So, no definition of cardiac death that's agreed upon. Each transplant center is setting its own policies, And it can be very complicated when it gets to children or newborns and that sort of thing. But that really is one of the tough challenges. If you want to do something like try to warm the heart or cool the heart, there are different techniques. These are the ways in which you can try perfusion and temperature change to see if you can preserve hearts. Again, you don't have that clear cardiac death criteria. So now people are saying, hey, I think if you froze the body or cooled the body down and maybe put the heart on a side pump just to keep it oxygenated, you're still dead because we've called you both cardiac death and brain dead. But somebody else is saying, well, wait a minute. If you got the machine going and the heart is perfused and it's still pumping, then why did you think they were dead? The heart still works. And just to make things completely crazy, well, of course the heart still works. That's why you're going to transplant it.
It's so circular. And then you're also clamping off arteries to the brain to ensure that,
Correct. To make sure there's no blood flow back to disturb a brain death diagnosis. So let me put it this way. First recommendation for me, given the current situation, the push is on to get more organs. I think these newer ideas, donation after cardiac death, normothermic perfusion, and trying to use people in those circumstances as organ donors, I think that should be restricted to special units that know what they're doing.
Okay. Okay. Well, I mean, all of this is in service of trying to increase the supply of organs, which we know there's a severe shortage of. There's a long list, and the number of organs is much less than that list. So let's just talk about allocation now. I mean, I think that's of all the ethical issues in transplants, there's the questions of the definition of death for the individual patient, but on a more, macroscopic question, justice-based question is how do we allocate these scarce resources to the right people at the right time? And we have, as you mentioned, a system in place with sort of geographically based places, an allocation network that's sort of geographically based. That's been changing. These different centers and prioritization based on geography has been changing, I think. So how did it start? How did UNOS, the organization that's sort of quasi-governmental, start, and how is it being managed, and what is the general allocation approach?
So when we first started, there were no allocation decisions. Remember, it was living donation, and you were restricted to your twin brother. So not a lot of problems there. It was cadaver donation. It's always been true in living donation of a kidney. You designate who you want to receive it, and whether they need it first or need it second, or aren't really a great candidate. You pick the recipient. That's true till right up till now. But if you are using a cadaver donor, then you have a bigger pool of people who can receive it because of these immunosuppressive drugs. So the short answer in the early days, what people did was they took the most urgent cases, who was closest to death. That was for a couple of reasons. One, if the transplant failed, and they did in the early days a lot, then at least you felt you hadn't made the recipient worse off. So if you took people who were dying, close to dying, and they died anyway post-transplant, then everybody felt, well, we didn't violate do no harm because they were going to die, and they died anyway, and that's sad, but better to let that group go first than trying to take someone who might have months or years to live and trying to transplant them and kill them. The other restricted factors were, remember I mentioned we didn't have that airplane jet system and the perfusion boxes to move organs around, so geography mattered. You couldn't really move organs more than a couple hours. And you need to make sure that you had a plane, or maybe the state police were around to drive something. So, I mean, it wasn't really set up. Third, we had, as transplants kept going, proposals to let foreigners come here and get transplanted because the U.S. was one of the few places that did it. That led to scandals, particularly at the University of Pittsburgh, a prominent transplant center in the 80s, where it turned out that 50% of the organs were going to sheiks and emirs and people from overseas who were paying full price and jumping ahead of all the Americans on the list. People didn't like that. They wanted reform, and that's where we got the calls for a system. So get the thing organized so the jet planes would be available, get the thing organized so Americans had a reasonable chance to get a transplant, not just the highest paying foreigners, and make sure that, we had a system that would do matches of who was biologically the best potential match so that you didn't waste organs by giving them to people who were not genetically close, who weren't biologically close to the donor.
Mhm.
Slowly, what's happened is transplant got better and better. The drugs improved, the skill improved. And so we've been shifting from urgency to efficacy. Take people who are more likely to do well. And not everybody buys that. There are still people who argue we should still take the sickest. But I'm in the camp that says when you're rationing anything, if you have scarcity and you know you can save lives with a high degree of probability, that should weigh heavily on who's going to get the scarce resource. You don't want to take the person on the lifeboat with limited food who's almost dead and give them food knowing they're probably going to pass away anyway. So watch to see who might benefit more. And that is what the system has been doing across the board, trying to predict that.
So, Art, just to interject a quick question here. I read recently that the Secretary of Health and Human Services recently intervened in an OPO claiming that they were misusing organs, giving them to the sickest first and not giving them to the sickest first. And I'm wondering, I don't really know the details of that particular case, but is this an instance where that tension between sickest first versus most years, life years saved, maybe you could put it, is in conflict?
Yes, because there's been creep in the other direction, meaning I'm going to give an organ to Dom at the first sign of his kidney failure, whereas he could live many, many years before he would really need it. But he seems wealthy or connected or a celebrity or something. And so that's what Kennedy was complaining about. When he said sickest, he didn't really mean
Mm,
sickest. He meant people who would be in that range of, I need an organ, let's say within 6 months, and don't give them to people who are doing, relatively well, can probably endure a course of dialysis, that sort of thing.
mm,
It's like the old joke used to be, well, why don't we do transplants prophylactically, not even wait for you to get sick? The outcomes will be great. They'll be much better. Don't wait for anything to start failing. Something else has been going on in the background too, which is again because of the demand for more and more organs, people are starting to take organs of lower quality. So what does that mean? Well, an organ from an older person. Think about lung transplants. That's emerged as an area. But finding someone whose lungs aren't damaged by smoking, air pollution, high blood pressure, it's tough. So transplant surgeons who do lungs have started to say, well, look, I'm going to give it to somebody who's 50. If they
mm.
get 10 years out of it, all right, that's still pretty good. I'm going to do that knowing that the organ could fail, or the liver that I'm going to transplant. Maybe it's got an infectious disease now. We're starting to transplant livers from people who had hepatitis, but hepatitis C has medicine. Maybe we could cure the person even if we gave them a
Right.
liver with that disease.
Mhm,
Those are much riskier activities. We're soon going to see, by the way, HIV organs
mhm,
being given to people who don't have HIV, again, with putting you on a course of treatment right away.
mhm.
That's all in response to pressure to do more people, give more people a chance. Who in the system's deciding this? Committees meet as part of the regulatory system, heavily uh, made up by surgeons and transplant docs, people who care for people post transplant, a little bit of public input, and they hash it out year after year. They're also, to be honest, watching their own supplies. So if somebody makes a change and says, I want local organs used locally because they still seem to do a little better, the transplant centers in the Midwest get a little upset because that means fewer organs coming their way. Some people want to keep organs locally because they have high brain death rates because they have a lot of gun
Right.
murders and gun violence.
Mm.
Other people say, well, everybody in the country should be treated on an equal basis, so you should share. So we see those debates.
It's so interesting. And just thinking back now to, the history of allocation of dialysis and other very scarce resources that were new technologies in the 50s and the 60s, there were a lot of social criteria that played a role in who was going to get the dialysis machine. And, that's reflected in some of the organ transplant policies still probably today, although I know, there's been shifts in thinking around individuals who have alcoholism being
Yes.
eligible for livers. What's the latest on that? And do social norms drive allocation choices?
So again, allocation is, I can't put it any other way, complicated. It really goes in two big steps. One is who gets into the transplant hospital? Who gets admitted as a patient? That is not part of a national system. Every transplant center makes decisions about who they're going to accept individually. So that
Right.
means
So
120
like getting on the
places,
first list, basically.
the first list.
Okay.
I sometimes talk about it as a transplant funnel. To get poured into the funnel at the top end, you have to be admitted by a transplant program. So that means a couple of things. One, if you're a homeless guy dying of liver failure, you're probably not even considered by anybody because you don't make it to the hospital till you're dead or in extremis at the end. So you're out. Transplant centers don't take people in their 90s. They know that organs are short and they're not going to accept them. And you might say, well, who's going to do things in their 90s? Ask any oncologist. We do plenty of things on people in their 90s because there's no shortage of expensive drugs to use. So, but transplant does have rationing upstream. Illegal immigrants, some states yes, some states no. Can't even get considered. Although, by the way, last time I looked, every state was accepting donations from people here without papers. So it's an asymmetry. Okay, so you get past that, and then you have judgments. Dom Sisti's in prison yet again for his third time. Now he's in kidney failure. Are we going to list him? Well, some centers say no. I don't want to deal with a guy who's incarcerated trying to do a transplant. The prisoner has to come out. He's going to go back to a place where there's not great food and there's a lot of infectious disease and violence, and maybe we're not taking him. Another factor, we're a new program. We don't deal with complicated cases very well. We're only going to take cases that are relatively easy. So you can't come here,
Mhm.
and that means maybe you have to go far away to a place that does deal with someone who's medically a complex case. There's centers that still say no to people who are heavy marijuana users, even though it may be legal in the state. It's a
Mhm.
federal Schedule One drug, and I know of a couple of places that just don't do marijuana, much less other
For which organs? Just lungs or what?
everything.
No.
So, and then there's our old friend money. So remember, a transplant center, if they're considering doing a face, which we've heard about in the news, those cost millions of dollars. If you don't have insurance, you are not even getting in the door, much less getting considered for a scarce face to use. Uh, Complex transplants, like say multiple organs transplanted, they're not really insured. You better be able to come up with money out of pocket or crowdsourcing or the biggest bake sale ever seen. Money does play a role in what transplant centers take in at the top of the funnel.
Hmm. It's so interesting. You brought up face transplants, and I just want to ask a question about these kinds of transplants that are not necessarily of vital organs, but are, hands. What other ones are there? There's hands and
Uterus,
uterus.
hands,
Yeah. So the
testes.
right, the ethics around these kinds of transplants seem different to me in certain ways. Maybe just focusing on face transplants for a second. I mean, is what are some of the ethical challenges there? I mean, it seems like there's a lot of very interesting phenomenological experiences that the patient's going to have that
Yeah.
are really challenging, maybe, but maybe not. I don't know.
Yeah. So
And are they
you,
informed at all by the John Travolta Nick Cage film Face Off?
well, People ask about that, and they even get people coming in and saying, I wonder if I could get a face transplant for cosmetic, not criminal purposes, but cosmetic purposes. The operation is so horrendous that the only people who'd ever really want to do this are people who have so much facial damage that they can't even really be repaired by plastic surgery. So it's a massive operation that takes hundreds of doctors, no joke, and many months to even partially recover from it. So this is really restricted to people just with horrific facial injuries, burns, gunshot, that sort of thing. But just no face-offs, no cosmetic procedures here. A lot of tough issues. Obviously, the cost. So a lot of resources, a lot of money. Is this worth it? Normally, you're saving a life. You sort of say, well, it costs a lot for a heart transplant, but you're not going to be here if we don't do it. So, okay. Face transplant, when I first looked at it, I thought, well, maybe people could wear a mask or just wear cover. And it was kind of aesthetic. Then I actually was asked by some of the face transplant guys to meet patients. And it became very clear to me that it is life-saving because many of them commit suicide. Many of them can't breathe or eat or make tears. So they do have functional impairment, but it's really bad. It's they can't sleep. Their windpipe may be damaged. It just every physiological function is a wreck, much less appearance issues and social issues. So I shifted my thinking and thought, well, maybe it is worth the price. But nonetheless, there are those who would say, no, it's just millions of dollars is too much. Then you get into issues.
Well, it's also the risk. I mean, as you said, the surgeries are
Yes.
very risky, and you
Yep.
sort of wonder, is it, in the case of a hand transplant, is it worth the risk for that level of restoring function where it's
Right.
not
And the hands and arms that we hear about, remember, there are prosthetic devices.
right? Exactly. Yes.
You're trading off, do you want to offer this guy a prosthetic hand? I will tell you that they work better and better every year, the
Mm.
prosthetics. And the hand transplants, you're still on immunosuppression, so you don't have that problem with an artificial limb. So those issues absolutely come up with, you know, fights among the experts, usually the proponents of one or the other getting into it about which is better. You have also self-harming. A lot of the people with massive facial injuries cause them to themselves. Are they going to do that again and then you've wasted the whole thing? Do you think they're more unstable, so you may list them but not priority listing, so to speak?
Yeah.
There are people who get drunk and get mauled by a pet or something like that. Was that irresponsible? Was that something that you want to take into
I
account as an
feel like the
ethics
first
matter?
face transplant patient I remember was attacked
Of
by
course, one of the early French ones was attacked by a dog.
was it a dog or did that a pet monkey or something?
There was another one with a pet monkey. That was
Yeah,
in Boston, I think. There's been a pet monkey. There have been people attacked by their spouses who threw acid on their face.
right,
You got injured veterans from wars where they've been subject to terrible explosions. So some people say they go first.
right.
Military vets should get priority on this list. And I could go on, but there are many, many issues when you're trying to measure the ability to have an improved quality of life where you need to have someone who's going to do the rehab and be very compliant and be motivated. And, even when they get the transplant, they don't look the same.
Right, right.
That's going to cause issues potentially with a spouse or family members or the community. Who is
For
this
one's
now?
own self-identity. I mean, it sort of
Correct.
challenges your own sense of yourself.
Correct. So all those things have to be weighed against the reality that we don't know.
Hmm.
There's almost no empirical information to use to predict who's going to be compliant, who's going to accept a massive, after the two things that define our identity to others by appearance are our face and our hands, because you see them all the time. Start transplanting them, and
Mm.
it's really tough for a lot of people to say that's you. Now, they may not care because they also may say, okay, well, that guy died and now I'm a new person, and that's fine with me. And I'm not saying that's wrong, but the experience we have with all of this is tiny.
Yeah, yeah. Well, I'm just looking at the clock, so I have one or two more little things I want to touch base with you, Art, on, and be mindful of your time here. But just me, you're great at top three lists, so I'm wondering what your top three reforms would be to the current system, and how likely they are to be implemented in this current administration.
Well, my top three would be number one, consolidate the OPOs. There are too many of them. We don't need 50 anymore. Make them, maybe drop them down to like 15, run the country that way. Also ensure, given fewer of them, that they're better trained. They understand the difference between the need to get more organs and pressure and coercion and shaming people
Mhm.
into trying to decide to do things.
So it sounds like quality metrics need to be changed there, as you described
They do.
earlier on. Okay.
They do. Secondly, we need to reform what's called the Uniform Anatomical Gift Act, which is the legislation that lets you and me and Steve be organ donors. You fill it out and then you can register in a computer. Well, it doesn't cover faces and hands. By the way, it also doesn't cover sperm if you donate that after your death. We need a thorough revision to make sure that people know what it is you want to donate, what it is you don't want to donate. Some people say, I'm fine with my liver, not my face. And if you tell them, well, your face has to go along with signing this card along with your heart, then they don't do it.
How
So
about, let me just pop in and ask, what about a presumed consent type of model?
I've long favored that. I think we don't have to assume that people don't want to do this. Polls show that they do want to be organ donors. That's the overwhelming majority. It's not everybody, but it's the majority. Still, you can get just as good an informed consent if you say, we presume that Steve wants to be an organ donor, he's died. Is there any reason that you don't want to do this? You can get just as strong an informed refusal as an informed permission. But people are reluctant because they think you still will use that shift to not really pursue the refusal. I
I
don't
mean,
think that's true.
empirically, I mean, in some countries they have this, right? That in like
Yes.
in the EU, I guess, right? So has it helped with
About,
numbers?
te- about 10% increases. It's still the case that if the family box in any way, they don't do
Well,
it.
that makes sense.
Yeah, yeah. So it's not like an ironclad. It's not. There's strong presumed consent, Monty
Hmm.
Python style. We're here for your liver. We're
Right.
taking it now. Versus a sort of weaker version. The weak version is what you've got. The other thing we need to do is certify programs to be able to handle things like expansion for DCD, normothermic perfusion, and other maneuvers that can be used to try and get more people eligible to be potential donors. I don't think that's for everybody, every
Mhm.
team, every hospital to try to do. Reforms, God only knows. With this administration, I think they realize there are problems. They are oriented toward market solutions. I'm a little terrified they're going to come in and say, well, then let's just pay for organs to get more of them. And I do worry that will scare off people.
Mhm. And just to put a final point on that, Art, I know you've been opposed to the sale of organs for forever. Has your thinking shifted at all on this in terms of maybe kidneys, live donations, uh,
No, because it's
cadaveric?
hard to run one part of the system as a paid system and the other part is an altruistic system. People say, well, I could pay for a kidney. I got two kidneys, da 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 da. But then the heart guys and the liver guys are all like, well, we can't do that. We're not going to pay you for your heart and you'd have to be dead. Um, but here's what I did come up with something, and I believe it's important. We should pay people's expenses. So if you want to be a living kidney donor, then you should get transportation. You should get paid for time lost from the job. You should get childcare. You should get a hotel reimbursement. We should take care of your expenses. And I do believe also, even in that regard, we should guarantee you health insurance if you do
Yeah.
suffer an adverse event from being a donor of a kidney or bone marrow, for example. So I do think there's a place for reimbursement, not in favor of outright payment. But yeah, I think we could make it easier to be a living donor.
Okay. Well, Art, this was really a great conversation. There's so much more to talk about. Maybe we'll have you back to talk about the system in China, which is all kinds of crazy and not so great. But in the meantime, Steve, unless you have other thoughts, I think we can begin to wrap up here.
Yeah, thanks, Dom, and thanks so much, Dr. Caplan. You've been a wonderful guest, and today was an example of several episodes where we've had topics where I have no background coming in. So I feel like I learned a ton today. Hopefully, our listening audience who may not have that background found this to be very interesting and informative and helpful.
Now,
Uh,
one thing I can jump in and say by way of my final thoughts, I was an early entry into transplant ethics. I don't think enough ethicists have jumped into this field. It's rich, as you can hear. You know, you can go on and on for hours about all the different issues there are. But this is a great area to see how bioethics and ethics have long worked with medicine. They have not been in opposition. This isn't a place where the ethicists are running around saying, don't do this, don't do that. Trying to carve out ways, whether it's brain death or an altruistic system, or how do you get rules for living donors, or what's fair allocation. This is a pretty nice example where I think everybody has been able to at least try to work together to make a more just and efficient system. It needs reforms, but that's true for everything. You wait 50 years, you got to
Yeah.
go back and fix it. But I actually would say this is one of the best examples where you get a good marriage between the ethics and the medicine.
Yeah. Well, and it also touches on so many philosophical and ethical issues up and down the board from the, concept of death and dying to allocation questions. So there's any number of, ethical challenges that a young ethicist out there might want to take on.
Want to grab onto. Yeah, and we didn't even get into the whole world of pet transplants. There are many cats running around today with kidney transplants at very huge expense. I'll leave that to some other expert.
is a pet transplant like when your kid's fish dies and you replace it with one that looks exactly the same?
I believe that's a whole body transplant. Yes, I've done that with a hamster in my life. Dead hamster replaced it. Zach, my son, didn't seem to know at the time. Good.
Right. Well, thank you again. This really has been extremely interesting, very informative, and I hope the listening audience enjoyed this. And please stay tuned for the next episode of Medical Ethics Unpacked.